at the top of the hour. We are so grateful that you have joined us for this. My name is Hillary Lum. I'm a physician at the University of Colorado School of Medicine and the Multidisciplinary Center on Aging, and it is really our privilege today to present, and we are grateful that you have chosen to spend this time with us, whether in person or perhaps you're listening to the recording. So we are spending our time talking about race-based stress and trauma, specifically for older adults, and we hope to leave you with some practical next steps. So in terms of just a little bit of housekeeping, we'll have 3 presenters who will introduce themselves in just a minute. This will be a moderated discussion. You'll notice that we have disabled the chat. We have a very diverse audience with more than 700 of you who have expressed interest in this topic and have registered. So to determine that the flow goes well and we can all have as coordinated of an experience as possible, we will hold questions until the end, and we will be interested in your input. So look for that Q&A, save your questions, and we also recognize that we won't be able to cover everything. Our goal for this forum is to introduce and explore practical ways you can engage in further inquiry and action related to this topic. We recognize that this is a patient care issue, just as race affects many aspects of our lives and communities. We believe that racism affects patient care such that we wanted to bring together this discussion about next steps that we can all take as we engage in this work. So as we recognize that we cannot cover everything in this 90 minutes, we still do hope that you might have some clear takeaway points, and we will provide references, again, a recording of this video, as well as a resource list by email and posted to websites. We do hope that as you're listening and engaging, you will commit to how you might be identifying people in your organization or your community, your clinical setting, that you can have some follow-up conversations about this, potentially to debrief it, and continue to actively engage in this work. I want to express special thanks to Jody Waterhouse of the University of Colorado Anschutz Multidisciplinary Center on Aging, and also to Brian Stice and Courtney Bowers as leaders within our Colorado Veteran Community Partnership. As I mentioned, you all who are participating in this as viewers represent a very diverse audience. We know that many of you are healthcare practitioners from different interprofessional backgrounds. We know that you may be here in Colorado or nationally. We know that you may be in a community-based setting or within the VA healthcare system. We also recognize that you wear multiple hats, and this topic is certainly cross-cutting, as you may be both a practitioner and a care partner, just so many different roles that you play. So with that, I will transition us to introducing our panel. So I'll ask Melinda and Dr. Young, so Dr. Trujillo, Dr. Young, Dr. Farrow to turn on their cameras as we do introductions. And we'll start with Dr. Trujillo. Would you be willing to give us a brief introduction and share with us why it's important to you to be engaged in this work?
Hi, my name is Dr. Melinda Trujillo, and I am a psychologist for the Portland VA Medical Center. I'm also in private practice and offer community consultation regarding multicultural counseling issues, diversity, and inclusion. I serve on the VHA National Race-Based Stress and Trauma Consultation Team, as well as the VA Psychology Multicultural and Diversity Committee. And so I'm very passionate about these concerns. And what makes me want to keep doing this work and, extend myself to the greater community is that, in particular, race-based stress and trauma is an ongoing, persistent, and systemic issue that is complex throughout our country and throughout our world. And one way of, giving myself hope, but also feeding my local and more global community is to keep doing this work, even when it's hard, even if it's painful. And so that was one of the reasons I became a psychologist, was to start working at changing some of the disparities both people in my immediate personal sphere and myself have experienced in a more local and global way.
Thank you. I was able to unmute myself. Thank you very much for that introduction. We're excited about your kicking us off. Dr. Young, can you please introduce yourself and share your passion?
Yes, good morning. My name is Dr. Anthony P. Young. I'm the president of the Denver Rocky Mountain Association of White Psychologists and also a past national president of the Association of White Psychologists. I've worked in Colorado for about 43 years as a clinician in mental health centers in our state hospitals, as well as having been an adjunct professor for about 26 years at the University of Colorado at Colorado Springs. And it has just always amazed me at the number of professionals in the field, as well as my students, who have absolutely little, if any, accurate information about cultural diversity, cultural inclusion, how other Americans who are non-white experience this reality. And this type of work is very important to me because we find that regardless of what type of training you've had, very few people have required classes in graduate schools dealing with cultural inclusion. Usually, if they offer it at all, they're electives. And we continue to produce, as a nation, thousands of medical professionals and mental health professionals a year who really have no clue about how to work with people of color effectively. So this whole issue about inclusion and diversity and cultural competence is very important to me because, as Dr. Lewin mentioned earlier, this is a patient care issue. If we're not able to effectively interact and to understand the people that we're working with from a cultural vantage point, we find ourselves acting out some of the stereotypes and misinformation that most Americans grew up with. So this is ongoing work, and it's very important. Thank you.
Thank you. We are very grateful for your expertise and commitment to education, both the current generation and passing on to all of us in our different interprofessional backgrounds, how we can be involved in this education and this work. Thank you. Dr. Samantha Farrow, please introduce yourself and your commitment to this work.
Yes, thank you so much, Dr. Lum. I am very honored to be a part of this panel. My name is Samantha, and I am a psychologist and an integrated behavioral health provider in geriatric primary care. And I am very committed to and passionate about anti-racist action and work because I care very deeply about the health of both my patients and colleagues, as well as my own family and community. I believe that racism and white supremacy culture significantly and negatively impact health and safety. And I see that in my professional role as well as my personal life. And as we'll learn today, the evidence on this is pretty clear. So I believe that white people, and especially white healthcare providers like me, have a responsibility to support and advance anti-racist work. And I'm just here today to share some of my knowledge and encourage other white folks and white providers to engage in new ways with this work. So thank you so much for having me.
Very glad that you're here, and I love being able to partner with you within our clinic, and it's because of an email that you received from Dr. Trujillo that we began envisioning today back in June. So thank you all for being part of this panel, and I want to also just continue to welcome those of you who have joined us for this symposium. The chat is disabled, but please do keep an eye on the questions that you may have. We are going to work to have Q&A at the end. we all enter into this from very different places, so we wanted to start with a definition. This is a definition that Dr. Young provided to me, and I want to make sure that we all have a chance to read this. I'm not going to read it to you, but instead I'm going to have us sit with this for 30 seconds, which feels awkward, and we all know that 30 seconds is actually not a long time at all. Thank you for, again, joining us, being willing to engage in this discussion about this relevant topic. Now that we have this shared discussion of white supremacy and racism, I'm going to transition us to our first presenter, Dr. Trujillo. And I'm going to be monitoring her, moving her slides, but I'll invite her to turn on her camera, and she's going to be talking about what is race-based stress and trauma and why does it matter.
All right, thank you everyone. And so I will be talking to you about what is race-based stress and trauma. And if we don't mind going to the next slide, please. A lot of us, when we think of race-based trauma, we think of overt issues of racism, which of course matter, such as the deaths of George Floyd and Breonna Taylor and numerous other Black and brown folks throughout the history of our country that have been brutalized or killed because of race-based trauma. And these events do matter and continue to matter and continue to happen. But that is a lot of times what people think when they think of race-based trauma. For example, I came up in the 90s. I remember Rodney King, that still comes to mind when I think of overt race-based trauma. But I think what also people need to be aware of is that race-based trauma, of course, is those overt, very traumatizing, brutalizing events. And by no means do we want to minimize them, but it's not just a one-time discrete event. Minorities in this country, people of color, there's an accumulative experience of racism as traumatic. One of the psychologists who has led the work in race-based stress and trauma and intervention is Dr. Monica Williams, and she defines it, she says that a minor event can be the last straw in a series of ongoing, persistent, acute, and severe daily forms of racial stress and trauma. The cumulative effect of racism and threats of racism. One of my favorite quotes about race-based stress and trauma, it's like death by 1,000 cuts. And I'm going to, in the next slide, define what are different types of race-based trauma. But I just want you to imagine, for example, I am Latinx and white, but because of the way I appear to the world as a white person, my partner, my children, my extended family, I can walk out my door and not be afraid of being brutalized. I can go to a store and I will be treated with respect. I can be pulled over by a police officer and not be afraid to die. And that is not the same privilege that my own immediate interpersonal family and friends who are visible minorities have, and other people in this country who are people of color have, and in this world. And can you imagine going out every day as if it's like a war zone, never knowing what's going to come at you? And so there's other forms of race-based trauma, racial harassment, discrimination, racial violence, witnessing race-based stress and trauma, and that could be these more macro level or discrete events, but also what it's like to be a person of color in this world, and to, even if it doesn't directly happen to you, to constantly witness it happening to people who look like you and are like you. What I really want to point out that a lot of people haven't thought about is the viralization of Black and brown death. For example, after George Floyd was killed, it was on every news source, every social media feed. They made memes of his death. And what is that like to sit there and realize that person looks like me? But not only does that person look like me, that person could be me. And I tell you, I've been sitting in these rooms day after day with my clients of color, sitting within my own community and sitting with that pain. And well before it was nationalized, well before, I mean, these events continue to happen and have been ongoing. But what it must be like to feel that. Incarceration, mass majority of the people behind bars in our country are Black and brown, are minorities, and it does not represent the actual representation in the community, not to mention the systems of institutionalized racism that create the school to prison or the prison pipeline for people of color. There's the overt racism, you know, maybe using explicatives that we're all well aware of, like the N-word or other horrific words that refer to other groups of color. But there's also covert racism. The way I would explain it is like you feel it in the air, you know? And if you are white passing like I am or have white privilege, you may not be aware of it. You may not feel it. Like, for example, my best friend is Latinx and white like me, but she is more of a visible minority. When we walk into a store, I get treated with respect, she gets tailored. And when I was 20, when we were first hanging out, we went in and she said, wow, I'm amazed. People offered me samples and people did this. And it struck, even though I grew up in a multi-ethnic family, I was like, whoa, I became aware. And you just imagine that and times that by 1,000. Unconscious bias, whether it's intentional or unintentional, that everyday slights and disrespect that people of color experience because of the way people treat them, verbally, non-verbally, environmentally, and systemically. Sexual trauma and interpersonal violence. So I think we can't talk about race-based stress and trauma without talking about the different way it impacts people. One thing is that racial trauma is not, there is no beginning and an ending. You know, I work with veterans, and combat trauma is horrific, and other forms of trauma like military sexual trauma, and I don't want to minimize it in any way, shape, or form, and that can also be race-based as well, but there is a beginning and an ending. With race-based stress and trauma, it's a continual event that continues to happen. And if you imagine what it's like to be a person of color in this country right now, where you can't turn on anything without seeing people like you being brutalized, without seeing people minimize or somehow misuse even advocacy for folks like you, there's this persistent vigilance, and it's needed. You need that hypervigilance to survive this world. But that takes a role. It takes a toll. It can lead to depression, anxiety, intrusion. The inability to get the thought of what happened to you or what happened to people like you again and again. It's like a nightmare that won't go away. This can lead to feeling apathetic or burnt out. I've seen, for example, many of resources that have been put out had titles like, what is it? Skills for being a person of color surviving this world right now. And that is not a minimization. It is not a minimization. It can also lead you to question your sanity. When people not only tell you that you're wrong, who you are is wrong, and that in some ways you're not even human, it can make you question every aspect of yourself.
Yep, go right ahead. There's a little bit of lag, and I'll just pause here. If anyone is having trouble with their audio, I have a phone number that you can call in and a code. So we'll take this little break here. You could call 404-397-1596 and enter the code 199-995. 8446. And I actually think that may be in the reminder email you got. So if anyone is having a lag with the audio, I know there's a little bit of a lag with the slides. that may work well for you. Sorry about that, Dr. Trujillo.
Yeah, it's okay. We're all being flexible. That's cognitive flexibility is the times, right? This can lead to physical health impacts, sleep problems, low energy, memory and concentration problems, chronic stress. All of us are healthcare professionals. Most of us, I assume, are aware of the huge health disparities that people of color have compared to majority culture folks. This has been exemplified by COVID and how 50–60% of the deaths for COVID are people of color, and that is because of health disparities, and that's directly related to race-based stress and trauma. How does this impact our daily lives? It can lead to decreased participation in health behaviors like sleep and self-care. It can lead you, just like other folks who survive the combat zone, to engage in behaviors to kind of numb out and get a break, even if they're not healthy, like alcohol, drugs, and other risk behaviors. Withdrawal, isolation, disengagement from value-driven, meaningful behaviors. And I just want to point out that when you're told that how you perceive the world, who you are, and what you value is wrong, it can make it hard to stay hopeful and find meaning. It can also lead to poor performance on vocational tests and achievement-oriented tests like stereotype threat. And now what I want to talk about is the social and interpersonal impact. Reduced access to employment, housing, and educational resources. Basically, they've shown that even if you made all of the folks with marginalized identities, in particular people of color, have the same monetary access, that if we don't fix what's happening with employment, housing, education, and systemic racism, the same exact things that are happening right now with disparities would occur again. It can lead to increased exposure to risk factors, police brutality, ethnic violence, all of the things I listed in terms of the forms of race-based trauma, and it can lead to a devaluation of the self, what we call internalized oppression or acculturated oppression, meaning the culture we soak in, even if we consciously don't espouse it, we still might subconsciously and internally take in those messages. I just want to point out, for example, a lot of people have a problem with the title Black Lives Matter. And the reason that movement was started is Black folks were, of course, for advocacy and social justice, but we matter. And there's been such a pushback, like that by saying they matter, that it's somehow wrong. They're saying that not that only they matter, they are human and they deserve to be treated with respect, and that we're having such a pushback and such a reaction. That's part of privilege if you're a white person, if you have that reaction to just the word Black Lives Matter. So that's why a lot of work for race-based stress and trauma is a rehumanization of the self. And you can imagine how that expands in interpersonal relationships, and it can lead to dehumanization, marginalization, and disenfranchisement. So I know some of you are hoping to maybe learn practically about some of the intervention strategies that we have both in the VA and outside the VA for race-based stress and trauma. So as I mentioned, I am part of the VA Race-Based Stress and Trauma and Empowerment consultation group for the VA healthcare system. And my colleagues have developed a group intervention that is for veterans of color that's designed to address race-based stress and trauma in a safe and validating environment. It's both culturally informed, culturally centered, and patient-centered. Some of the themes we explore are the racism's impact on mental health and physical health, power and privilege, systemic racism, race-based stress and trauma, and also the intersection between military and race-based stress and trauma. And we also have a huge empowerment and resilience component, as well as advocacy. This group also teaches coping skills, and by teaching coping skills, we're not saying it's the responsibility of people of color to solve racism or to solve their own distress, but as I mentioned, racism and race-based stress and trauma takes a toll. It is like living in a combat zone, and so part of the reason we teach skills is to help people take care of themselves. One of my favorite authors of color says, self-care is a form of self-preservation and self-actualization. And so we do emphasize skills, and we also talk about how to, work within systems, and small or large, when you're experiencing race-based trauma and advocacy, and we connect people to these types of skills through practicing them in group, actual advocacy. As group leaders, we do a lot of advocacy, connecting to community and community resources. The veterans also share a lot of their own resources and advocacy. If you would like to learn more about this group intervention, the co-leads for the consultation group and the actual intervention itself are Dr. Maurice Ensley and Dr. Keisha Ross, and those are their information included in the slides. So you can email them if you want to learn more information about this specific protocol.
Thank you so much. My video is coming back on. I appreciate this introduction so that given the diversity of our audience today, we can see the multi-level complex impacts of race and racism in our lives. I wonder, as you think about this, what keeps us from doing this work? And would you be willing to share a story? And then I know you have some slides related to this.
Yeah. I think one of the biggest things that keeps us from doing this work is a fear of leaning into our own discomfort, especially if for some of us that we're on the upside of power. For example, I am a person of color, but I have white privilege, right? And talking about race and racism is uncomfortable, especially if you're not on the receiving end of it. So and I'm going to talk about myths and things related to that, so I won't go overboard, but I think that's one of the biggest barriers, is that if people are from a majority culture, they don't think they have the right to do it, or the space or the place to do it. And I think the problem is that then puts the ownership of fixing race-based stress and trauma or healing from it on the people who are on the receiving end of it. And that is one of the biggest barriers. I'll just give you a very brief example. I am one of the co-facilitators for our race-based stress and trauma group at our VA. I saw this huge disparity, so I actually years ago reached out to Dr. Ross and Dr. Ensley wanting to learn more, because I'd done one-on-one work but never at a group, and we didn't have anything like that in our VA. And so both I and my fellow co-facilitators, Dr. Sara Zuniga, she's Latinx, Mexican-American, and when we were promoting it, many of our fellow colleagues who I very much respect, even might consider white allies, or even came to us and said, oh, we're glad you're doing the work. And when they said you, they didn't just mean, oh, Dr. Zuniga and Dr. Trujillo because we're trauma specialists and we do diversity work. They basically, some of us directly said, because we were people of color, it was our work. And what it made me feel like is, so it's only my work to do. And then obviously we can't cover everything in that one group. So when we have veterans participate in our group, it is the expectation that they have an individual provider who will continue to do the work with them. But I've actually had providers say, I can't do it. I'm not able to. I don't have the skill set. And some of those things, I don't know about the can't, but the skill set, there might be some truth to that. But if we don't have people doing the work throughout the system and being willing to lean in their own discomfort, it won't be enough.
Yeah, thank you for that story and your practical experience. Tell us about some additional myths that you are aware of, and we'll walk through this section.
Yeah, and so I want to talk about others, and I want to say that this even comes up for me. Most of us, whether you're a healthcare professional or in a mental health field or any other provider in the VA or larger system, we typically, one of the main values that brought us to this work is we want to help people, right? And so I give a lot of different types of diversity and inclusion trainings, race-based stress and trauma. And typically we do like a experiential where we ask people to talk about when they've engaged in bias. Most people will be able to say, oh, this is when a patient did it, this is when my peer did it, but we don't see ourselves as part of the problem. There is this myth that helpers do not hurt. But the reality is, one of my favorite quotes about bias and oppression is, it's an equal opportunity virus. We are not immune from the culture and systemic racism that we either on the receiving end or the privileged end of. Being a helper does not prevent you from engaging in these behaviors. In fact, everyone does it. But because everyone does it, it means we can change if we work together. So we need to kind of check ourselves and own our own hurtful behaviors. Another thing too is that, and I basically said it, is that we don't have biases, and it pretty much connects to the last slide. And we all have bias. In fact, research has shown again and again on conscious and unconscious bias is typically we can still have biases even when we consciously think that we don't have them. I'm going to give you an example. I grew up in a large Latinx family. Many of my family members are men of color, and I don't think I have a negative assumption that men of color are more violent, but I took one of the online implicit bias tests, and I came up as like a mild to moderate unconscious bias of men of color being more likely to affiliated with violence, you know, and that's not something I espouse to believe on my logical brain, but it's still there because I'm not immune to the society that's around me. Another thing that really comes up, I know that not everybody here is a VA provider, but I have heard again and again, like, and we've even had memos come out, like, being an ally, an advocate, and an anti-racist, it's too political, or it's not in our scope of practice. Like, this is not our role. That's for social justice warriors. That's for, you know, advocacy groups. That's not our work. What I want to say is that APA, the American Psychological Association's vision statement and guidelines and ethics codes actually support psychologists using psychological science and knowledge to inform policy and promote systemic change. And not only that, they now see knowing the DSM as just as important as being multiculturally competent. It's not an add-on, it's just as important. And I know that many other professionals have similar guidance. One of the silver linings of all this horrific race-based stress and trauma that has been happening is we've been seeing all these great forums from many disciplines espousing these same values and doing the same kind of work, and that's what gives me hope. That's what helps me keep going. And one other thing I want to say is that if you do work for the federal government, the Hatch Act does not apply here, and the Hatch Act basically says that if you are a federal employee, you can't advocate for a particular political party while you're on the job, and that doesn't, but you can talk about how the current socio-political context impacts your veterans of color or your clients of color if you do work within the federal system. And they've actually put a lot more guidelines out about that more recently. Another thing I want to say is that there's this, I don't even like the word cultural competence, but we use it all the time. It's like this idea, kind of like a CE certificate. I'm competent, therefore I'm done. You know, I took that training in grad school. I went to that race-based trauma forum. I'm good, right? It is not an endpoint. We never are truly competent. We must continue to work on diversity, inclusion, equity, anti-racism, and allyship as ongoing skill sets. And the reason for this is racism doesn't end, right? Racism has not ended. It's existed. We were founded on slavery and caste systems and patriarchy in our own country. It was written into our laws, and it's not going to end because we take a CE certificate. Now, of course, I support further knowledge on this, but we got to keep doing the work. And I got to tell you, I've been doing this work formally for 15 years and informally for a while. And I make mistakes. You know, even in my race-based stress and trauma group, I've you know, unintentionally said microaggressions, and I've had to own that, you know, and I continue to do that, but it's uncomfortable. One of the biggest things that I think gets in the way is that we should only talk about race or race-based trauma if a client brings it up. I've heard that again and again at consultation meetings, trainings, especially from majority culture or providers on the upside of power. I don't think that we should do that. In fact, I think we need to invite conversations about race, race-based trauma, and culture consistently and persistently. And I want to emphasize, not just when the murder or mass brutality against BIPOC folks demands discussion of it. I'm glad that people are becoming more conscious, but what I want to say is if you didn't see race-based trauma and systemic racism, that's a privilege and that's a problem. But the good thing, since we are all in the field of change in one way or another, is once we can see it, we can do something about it. And finally, I just think we should normalize race-based stress and trauma in our everyday practice.
Thanks so much for your comments, and that may have been your takeaway point, but you've said a lot. and what might be a recent learning point or reflection related to your commitment among the things that you've shared with us. What are you currently working on?
You know, I think two things. I think I continue to lean into my own discomfort, right? And so, like, I have gotten more vocal, like, not that I'm not known to be a quiet person, but like when something's making me uncomfortable, instead of talking around it, I've just been even more direct than I naturally am as a person. I think we all kind of we're so worried about our guilt or our innocence or appearing wrong that we just don't do it. And I've been learning to do that. And I think I've also been learning to like say no. I want to say that for your BIPOC providers, like we're experiencing so much right now that I want to help everyone, or I want to be on every committee, you know, and so that's the other thing I would say to majority culture or people on the upside of privilege and power in one way or another. If you want to outreach to your fellow providers of color or even clients to do this work, ask if it's in their bandwidth, like check where they are just as a person. So that's some of the take homes I would say more recently.
Yeah, thank you so much. I appreciate your thoughts, and we look forward to the Q&A. Again, we will have Q&A at the end, so we invite you to keep your questions. So we'll transition to our next presenter, and I'll pull up slides. So Dr. Anthony Young, I invite you to turn on your video, and he will be speaking about America's original sin, trauma caused by domestic terrorism, and focusing our discussion on practical aspects of care related to African American elders and trauma. So thank you, sir.
Oh, you're very welcome. It's good to be here, and we're very happy that we have this opportunity to engage in a courageous conversation, because we do know that by and large, Americans are not very well knowledgeable about each other's history. Now, all of us, for the most part, have been exposed to public education, and we've been given the typical type of history about Europeans having conquered the Western Hemisphere, but we really have not learned very much about the other people in this country, people of color, African Americans, the indigenous people, etc. So I would like to spend just a moment talking about domestic terrorism from a psychosocial historical context. And once again, I engage all of us to be a bit open-minded as we look at this whole issue, given the fact that our public school system does a very poor job in teaching about the true history of America and how many people, African Americans, indigenous people, Latinx, have also been traumatized throughout our history. And the background that I would like to give you is for you to keep this in mind as you work with people of color, because certainly, even though many clinicians are unaware totally about some of the history I'll give you, it's important to kind of keep this in mind, because this is the context in which we live. And there's a lot of denial and distortion and just outright ignorance about how other Americans have experienced this reality. So when you find yourself in a clinical situation with a person who does not share the same phenotype or ethnicity or quote-unquote race that you have, it kind of can lead to a lot of misinformation and misdiagnosis unless we're very careful about these issues. So I'll begin with talking about a little bit of the history of the trauma caused by domestic terrorism. Too oftentimes when we think about that, we think about people from other countries. We just acknowledged 9/11 a few days ago and that type of terrorism. But the fact of the matter is that indigenous people and African descended people were terrorized from the very moment Europeans began to colonize the Western Hemisphere. So we can go back to 1493 when Columbus had his second voyage. And from that point on, we felt that the indigenous people of the Caribbean and Africans who had been captured, kidnapped and captured and forced to work for hundreds of years. We're talking about before America became a nation, but we can go back as far as 1493. So I would like for you to just think for a moment, visualize the type of trauma caused by being kidnapped, enslaved, separated from your family, raped, murdered, mutilated, and really worked from sun up to sundown and when worked to death, being classified and treated as something less than human, having absolutely no legal or human rights, according to the U.S. Constitution later, and for hundreds of years, and we're talking about from 1493 up until now, suffering from the residuals of enslavement, including Jim Crow, racial discrimination, and every other type of human endeavor since the end of the Civil War. So we're looking at about 135 years post-slavery, still having to deal with discrimination in various ways. So when we think about the type of studies done by the U.S. Department of Health and Human Services to talk about the physiological or some of the medical health disparities caused by race-based stress, which result in a number of preventable diseases. And from a behavioral health vantage point, looking at the higher incidence that people of color, particularly African Americans, suffer from due to substance use, depression, and anxiety, all which oftentimes not only has its roots in the day-to-day struggles that human beings have, but you add to that having to deal with white supremacy. And I would refer you back to the definition that Dr. Loom gave at the very beginning of this presentation. And there have been study after study that talks about the economic disparity in wages. For example, African Americans make about 51% of the wages of white Americans, given the same educational and work experience. All of those factors being equal, still only about 51% of the wages. And as we look at the educational curriculums throughout the country, there are a few exceptions, we know that, but for the most part, when we look at public education, it has been non-inclusive in any meaningful way of people of color. And there's been an ongoing denial of college programs for admission, as well as into the various graduate medical schools and psychology programs at the graduate level. And of course, we know about the negative stereotypes, the racial profiling, the higher incidence of police brutality, which has occurred throughout this American experience. And we add to this voter suppression, housing discrimination, such as redlining. We can go on and on and on, and get a feel for the type of stressors that African Americans particularly experience as a result of centuries of racial discrimination under white supremacy. So oftentimes we find that what happens when we talk about people of color, there's this notion about victim analysis. So there's a ton of research and work done on identifying the type of suffering that people of color have experienced, but not enough effort has really been made on how to explain how such conditions have existed in this country, which we pride ourselves as being a land of freedom and opportunity, yet we have this massive culture of white supremacy which has existed since the inception of America. So it's very hard for many people to come to grips with the fact that there's a major contradiction. So we have clinicians who have been produced in medical programs and psychology graduate programs who may have absolutely no clue or no real feel or empathy about the history that that the people of color have had in this country. So asking those difficult questions about trauma is something which may not very well come up very easily. In fact, when we think about the type of misdiagnosis which occur, and Dr. David Satcher, in his 1999 report, by the way, Dr. David Satcher was the former U.S. Surgeon General, and he wrote the first report on mental health and race and culture and ethnicity. That was a supplement to his 1999 report on mental health. Basically, when he talked in the supplement in 1921, excuse me, about the type of misdiagnosis which occur not only in the emergency rooms of hospitals, but also just in the daily practices in their clinical experience. We know that oftentimes people who have suffered trauma may be misdiagnosed as being paranoid schizophrenic, when actually, when we look deeper into their experiences, you may find that there's a history of trauma which may be a better explanation for their experience. In fact, I would dare say that when we look at diagnosing African Americans particularly in terms of paranoia, you might ask yourself whether or not there might be a better explanation for some of the perceptions that clinicians have. There's something known as justifiable apprehension. And given the history of African Americans in this country and other people of color, what we find is that rather than being quick to diagnose someone as paranoid or even having paranoid characteristics, we might take a closer look at the type of histories that the client may have, which may be justifiable apprehension, which is a typical distrust of medical professionals due to a legacy of misdiagnosis, mistreatment, medical experimentation, and most of you should be aware of the history of that, as well as discrimination by medical and mental health professionals overall. I'm going to share with you an example of what race-based trauma may look like in African American elders. While I was working as a clinician at the Colorado State Mental Health Institute in Pueblo, which is basically a forensic hospital in southern Colorado, there was one patient on my caseload who had actually been hospitalized for over 26 years. He was a 75-year-old African American male who was diagnosed with paranoid schizophrenia. Some of his background is that he grew up in Mississippi and was traumatized after witnessing lynchings as a child and the ongoing type of racial discrimination in that area. His experience of trauma was actually ignored or dismissed as being a delusional production throughout his hospitalization until the time that he came to the community reintegration unit, which actually took the time and made the effort to assess his traumatic history and to treat his trauma. And another part of his background is that after growing up in Mississippi, under some very traumatic cultural and personal circumstances, his family moved to Colorado, and he found himself re-experiencing some of the trauma with his interactions with police authorities. Ultimately, he ended up at the state hospital, and that's where he stayed for about 26 years. Now, I should mention that during his hospitalization, the whole issue of his trauma never really came up. And there was a hesitancy by medical staff and psychologists to even ask about his cultural background. So the issue of his trauma, there was there was very little information about that until we began to delve into that during his time in the community reintegration unit. And we found that not only did he have that type of trauma, but throughout his entire time at the hospital, that was being missed. So we began to treat his trauma, and ultimately, after a couple of years, he was able to be discharged to family members who had moved out of state here. Unfortunately, he died of cardiac complications a few weeks before being discharged to family members. But once again, my point is that his whole history of trauma had been totally ignored and missed. So the point is that we have to be willing to ask some of the difficult questions about someone's upbringing and some of their cultural experiences that might help explain some of the possible diagnoses that we may be actually considering. One quick example that I'll give you also is of a Vietnam veteran. He was an African-American Vietnam vet who suffered from post-traumatic stress disorder, but also pre-existing racial trauma, which was actually exacerbated by being in contact with racist white soldiers while in the Vietnam War. Basically, this soldier grew up in the Denver area, and he had served 2 tours in Vietnam. And during my time working with him, I was with the Disabled Americans Veterans Program, Department of Colorado, while it actually maintained a clinical program during the 1980s and 1990s. And while I was working with this veteran, he talked about having been confronted by racist white soldiers while serving in Vietnam. So even though he knew that we were, quote unquote, fighting for the liberation of the South Vietnamese, he was in constant conflict in dealing with this contradiction about why he had to deal with racism while fighting in the Vietnam War. Also, given the fact that he had dealt with a lot of racial trauma before he went to Vietnam, having this ongoing experience was something which really exacerbated all of his PSD symptoms that actually emerged during the Vietnam War and subsequently. So when we think about the experience of racial trauma, keep in mind that it's almost like peeling an onion. On one hand, on the surface, you might see a presentation of a lot of different clinical symptoms, but when you delve deeper, you may very well find that there's a lot of racial trauma underneath all of the presenting symptoms that you're making observations of. So some of the practical tools in looking at clients or should say people of color, keep in mind that it's always important to consider your own lack of knowledge and your own cultural discomfort and biases, and where possible, use clinical supervision or consultations with those with expertise in dealing with these racial issues so that you can begin to confront your own issues in a confidential setting. Also, it's very important to disaggregate the data when you look at racial disparities actually across categories or disorders. And that's that too oftentimes we find that a lot of the health disparities are hidden in the data, but once you disaggregate the data, it's one way to actually expose those disparities. And when we think about some of the efforts which have been made throughout the years to address racial disparities, the manner in which racism has been manifested within medical care and also mental health, we know that in 2001, the U.S. Department of Health and Human Services, through the Institute, through the Office of Minority Health, actually created the National CLAS standards. And the CLAS standards basically refer to the national culturally, linguistically appropriate standards. And these are guidelines, or basically a framework in which you can actually deliver culturally and linguistically appropriate and respectful services. And there's a lot of data actually available online, so I'm not going to go through all of the CLAS standards, but the fact of the matter is that as healthcare professionals, it's very important that we are aware of the CLAS standards, because while many states have actually adopted them, there are many which have gone as far as to actually include them within licensure standards. So if you go to the next slide, you'll see that, excuse me, can you go back one slide? Yes. So as we look at the national CLAS standards, there are 15 standards that actually cover 5 different categories. So it's very important that as you look at these, keep in mind that first and foremost, it's important that you keep in mind that the purpose is all about client or patient care, and that it's very important to be respectful of one's language, one's cultural health, beliefs, and also a lot of what happens in actually the implementations of the CLAS standards is the fact that leadership has to be on board with it. So the second principle of the CLAS standards deals with governance and being able to not only get the leadership, but also the workforce on board with implementations. The CLAS standards, and this will be my last note on this, the CLAS standards is a wonderful tool for every healthcare organization and every healthcare professional to be aware of, because this can only serve to improve the quality of healthcare for the people who we serve. Okay, next slide, please. Okay, a second tool which I would like to spend some time with deals with a tool which actually contained within the DSM-5. And the DSM-5 actually has in its appendix a wonderful tool which is known as the Cultural Formulation Interview. This was actually created by the American Psychiatric Association in 2013. And while on the one hand, many clinicians are unfamiliar with this, it's a tool which is readily available to you. And in fact, the APA has workshops online to help you actually address the full use of this tool. One of the problems with the cultural formulation interviews is that too oftentimes clinicians will not take time to actually conduct the formulation as intended. And if medical staff or mental health staff do not take time to actually ask these difficult questions and to look at the cultural identity of the individual and to understand how they will conceptualize their distress, they may very well miss some very important information, not only in terms of diagnosis, but also in terms of treatment. Let's move on to the next slide. Next. Yeah, so when we look at African American elders and trauma, it's very important to also keep in mind there are some other factors to consider. One, of course, is addressing the degree of acculturation. We know that African Americans and other people of color may be adequately acculturated, if you will, into quote unquote American society, but the level of acculturation has a lot to do with how well a person of color will be able to identify at a conscious level the type of cultural factors which may be important for you to actually be aware of. And when we think about the degree of assimilation, this is extremely important as we look at cultural identity and the manner in which someone may experience racism. If this area is ignored during the clinical formulation, you might miss an opportunity not only to connect them with social support systems, but also in terms of being able to address how racism or the client's experience of white supremacy has actually impacted them early on or later in life. And when we get to the point that we're actually asking about race-based trauma, I know with many of my white colleagues, this is very difficult because they feel uncomfortable talking about race, but it's very important that you become comfortable being uncomfortable, if you will, because these issues are not going to go away simply because we refuse to talk about them or to raise them during the assessment or during the treatment process. So it's very important to ask about the type of traumatic experiences that clients have had, and also to ask about cultural strengths. So oftentimes we may be so focused on dealing with the symptoms of the client's presentation, excuse me, that we might even forget to ask about cultural strengths, because we do know that in the healing process and through therapy, it's very important not only to identify which issues are being worked on in treatment, but to use the cultural resources and strengths of the patient to actually help in that healing process. And when we think about some of the practical examples of how this can be done, it's important to take time to consciously identify and to understand and resolve your avoidance of racial issues. Because unless you're able to do that, it won't be possible to do it, to actually conduct an adequate cultural formulation interview. Also, it's important to adequately identify and to access the resources and circumstances of the patient's trauma, and to address trauma in and to address trauma in therapeutic interventions with the patient. So that's very much key, because too often times, unless we're able to identify trauma early on during the assessment process, we may not include that in any subsequent therapeutic interventions with the patient. And also to value the patient's perspective of their life experiences and trauma. It's important not to be dismissive when we think about the type of the different experiences that African Americans and other people of color have had in this country. So being willing to value them and not to discount it, because it can be something very core in terms of the healing process. Okay.
Thank you, Dr. Young. Thank you for modeling this and sharing the depth of the challenge and how this really does not fit well in how our healthcare interactions are commonly pressured for time, and we may not know our clients, our colleagues, our patients, and their families and environments as well as we'd like to. Briefly, do you have a takeaway point from your perspective that you would leave people with?
Yes, my biggest takeaway point, and this is something which is it's very difficult, but this is what we're challenged to do. All of us as clinicians, regardless of what role we serve in, it's very important that we are in touch and aware of our own biases and the type of racial issues that we avoid talking about, because until we get to the point of confronting and resolving those issues, it will not be possible to provide the highest level of patient care.
Thank you. Appreciate your thoughts, and we look forward to more discussion. I'll transition us to Dr. Samantha Farrow, who is now going to share some comments on why is whiteness a part of a discussion about racism.
Thank you so much, Dr. Lum. I appreciate it. And many thanks to my colleagues, Dr. Young and Dr. Trujillo, for sharing their expertise today. I think they clearly have a depth of knowledge and experience that is amazing. So generally speaking, as it has been already talked about, it's typically uncomfortable for white folks to talk about our whiteness. This is because it kind of violates the restrictive roles we're taught about race, and namely that racism is not our problem to think about. But I just want to say for a moment, for white people to not talk about whiteness has tremendous life and death impacts on people and communities of color. To not address whiteness also curtails us from being effective in anti-racism work. It's my experience that we are all harmed by the cruelty and objectification that's at the heart of racism. And so even though the consequences are certainly higher for people in communities of color, when we dehumanize or we see somebody being dehumanized, everyone is dehumanized, and that includes white people. So the final focus for today is really kind of a call to action for my white peers and colleagues. We know that change does not happen without the engagement of people in power. And on this issue of race, that means white folks. And so today I'll be talking about and defining white privilege, what is white supremacy culture, which we've kind of already heard a little bit about, but I'll be going into some specific examples. And then finally, what does anti-racist action look like? So how can white folks appropriately engage in that? I want to first start with what is white privilege not? First of all, it does not suggest that white people do not have struggle or don't have problems or are not working hard or are bad people. What it is saying, and you can go ahead and go to the next slide, what it is saying is that we have received many unearned advantages, privileges, access to things, systemic favoritism because we are white. We know that this occurs on an individual, an organizational, and a systemic level. And it's almost always invisible and unacknowledged. We've heard that from Dr. Trujillo and Dr. Young about how oftentimes this is not discussed. And so actually, we go back one, some examples of how this might show up is that white people and white culture are kind of the norm. We're the neutral. So products that look flesh-colored or nude look like my skin tone, not someone else's. Hair care refers to products for my type of hair, and then there's a separate section for ethnic hair care. So white privilege is really about the notion that the world was made for us. My colleagues have already talked about how our educational systems teach white-centric histories, primarily of European-based individuals and values. Our media representation is overwhelmingly white, whether we're looking at TV shows or movies or children's books or toys. What we know is that when the world is made for white people, when white folks are the starting reference point, anyone who's not white is kind of seen as the other. And that leads to some of the consequences that my earlier colleagues have talked about. So we can go ahead and go to the next slide. So that brings me to what white supremacy and white supremacy culture is referring to. For most folks, when we hear that term, white supremacy, it conjures up images of extremism. Maybe you think of the Ku Klux Klan or the Charleston shooting in an African-American church, and those are examples of white supremacy. But white supremacy is actually a much more pervasive ideology and system, and we have all been born into it, whether we have wanted to be or not. It is these values that are rooted in white supremacy are kind of woven into the fabric of our culture and our values much more so than we may realize. And again, it's not acknowledged. White supremacy's power is drawn from its invisibility, where it can kind of live unexamined. And so white supremacy is defined as the belief that white people and white culture are superior to other races. And because of this supremacy, white people should have and control access to wealth, power, and privilege, and dominate other racial groups. We know that lots of us can think of historic examples of that, but I think it's really important to acknowledge that this is ongoing and it's systemic. It's happening even today. There's a fantastic resource that we'll be providing to our participants today that's in my references that kind of outlines white supremacy cultural values and gives some examples for that and also the antidotes for that. But I just want to say briefly a couple of examples, things like individualism, where competition is more highly valued than cooperation and individual recognition and credit is most prized. perfectionism, where the emphasis is not on, expressing appreciation for other people's work. It's much more common to point out how other people or their work are inadequate or flawed, and questions are asked to kind of prove others wrong or find their mistakes. Another example is a constant sense of urgency. A constant sense of urgency makes it really difficult to be inclusive or encourage democratic or thoughtful decision making. And another example is quantity over quality, where things that can be measured are more highly valued than things that cannot. The resources of an organization may be directed towards producing measurable goals. For example, the number of people attending a meeting or the amount of money spent may be more important to the organization or more highly valued than what is the quality of relationship, what's the democratic process for decision making, or the ability to deal constructively with conflict. So these are some examples that we don't typically associate with white supremacy culture, but they are a part of that. They're rooted in that. And it's striking to me, of course, I'm in academic medicine, but it's striking to me how a lot of these values of white supremacy culture are reminiscent of some of the values in academia. And I think then it's not surprising that we have difficulty with diversity, with inclusion, with recruitment and retention of students and faculty of color, because it can be a mismatch of organizational and cultural values. So then I want to go ahead and transition to my next slide and talk a little bit about anti-racist action. But before we get to what you should do, let's talk a little bit about the concept of paternalism, or this notion of saving people. I think paternalism by well-intentioned white people can potentially be a pitfall, and it certainly can undermine our effectiveness in anti-racist work. And this is because paternalism really is actually conveying a subtle sense of white superiority. It reinforces the notion of a deficit model. It sustains white privilege. And most importantly, it does nothing to challenge the systems of white privilege and white supremacy that we're operating in. In academic scholarship on race, this is often referred to as the white savior complex. And there are lots of examples of this in pop culture and movies. Earlier, we kind of heard Dr. Trujillo talk about how, helpers do no harm, and that can be especially challenging for white healthcare providers, where, we are tasked to some degree with helping folks and saving people. And so how do we kind of have this interaction between our identities as healthcare workers, but also our trying not to take a paternalistic attitude towards patients and colleagues of color. And the reason that that's an issue is paternalism is problematic because people of color are positioned as objects of white individuals' humanitarian endeavors. So it's still objectifying, it's still dehumanizing to them, even if the intention is to help. I kind of consider this the white supremacy version of what white engagement looks like. It's not anti-racist action. To actually engage in anti-racism requires white folks to shift our focus from saving people to transforming racist systems that are harmful to people. And we have opportunities to do that in our workplaces, in our communities, in our cities, states, nation, whatever level you choose to engage with, that's kind of what we're looking at. And so, so what does anti-racist action look like? First and foremost, we are so fortunate. There are communities of color and leaders within those communities that are just powerful resources. And so I think, first and foremost, aligning with BIPOC leadership, groups, organizations. And for white folks, this means kind of listening over talking. When we align ourselves with leaders of color and with communities of color, it means trying to understand the ideas, experiences, and needs of those organizations and groups over trying to be understood by them. I really believe that for us to be effective, we have to approach our role in this work with humility and really hold ourselves accountable to our impact, not just our intention. And so first and foremost, I think aligning with leaders of color and BIPOC leadership is a really key component. The next thing is engaging as a change agent. So we know that the status quo is inherently kind of rooted in white supremacy and racism. So how do we, engage in making changes with this? I think donating money is really important, especially given, wealth disparities by race, but it does not replace engaged advocacy. And I think particularly for white folks, we have a responsibility to take this on because we can use our white privilege to challenge racist policy and systems. People of color do not have the same access to predominantly white spaces that you and I have. And even when they do have access to those spaces, their voices are not received in the same way that ours are. And so I think, making sure that you are really engaging as a change agent in whatever level, whether it's your organization or it's in your community, it is critical. And the last point I just want to make is that educating ourselves about what racism is and what white privilege is and what white supremacy is, as our previous presentations have said, this is not a check the box and I'm done kind of thing. We know that racism is an evolving phenomenon in our country and in our system. We know that it adapts to different times and different cultural, generational differences. And so therefore transforming and challenging it requires ongoing education on our part and most importantly, self-reflection. The good news is there are amazing scholars and resources available, whether, attending a presentation like this, listening to the experts that have talked today, or talking about curated lists of books at your library, online TED Talks, lectures from experts. There are lots of BIPOC-led organizations that give classes and trainings. But first and foremost, I think white folks have to identify that this is an issue that is ours to address. We have got to take it upon ourselves to learn and then talk with our white colleagues, our white neighbors, our white friends. I just want to make one last point that I think it's really important. We've heard today how exhausting, painful, and traumatic racism and white supremacy are for people in communities of color. And because of that, as several of my colleagues have said, it is not appropriate to rely solely on the people of color in our workplaces or in our lives to explain racism to us or to kind of say, okay, you go ahead and you take care of the diversity and inclusion. I liken that to, it's kind of like going to a funeral and asking the bereaved family to comfort you. It just doesn't make sense. So I encourage all of my white peers and colleagues to approach racism as our problem and really engage with this work with sensitivity and humility. So thank you so much for your time today. Thank you for all the participants who are engaged and listening in today. We so appreciate that you're committed to this topic.
Thank you for those comments, and I'll invite our presenters to turn on their camera. Dr. Brian Stice has also opened up the Q&A, I believe, and so we'd like to transition to some Q&A discussion in the last 12 or so minutes. Again, as a reminder, we'll have a recording, the resource list, the reference list, and perhaps as we wait for Q&A to come in, I'll direct a question to Dr. Young. The three of you are psychologists, and I appreciate that you shared practical tips related to the cultural formation interview and other awareness that we can apply in clinical practice. What suggestions would you have to individuals who are not trained in psychology? I am a little jealous about how your tools are perhaps more integrated into your training than for myself within physician training. So Dr. Young.
Well, I would say first and foremost, just to be aware that it's important to have empathy, but also an open ear. We can actually take time to learn about people of color. There's a number of resources that they're listed in the references that we have, but more importantly, being willing to just experience someone else as a human being without judgment, if you will. And that's a real tough thing in our society because we're socialized to judge others as better than or lesser than. When we get into a space that we realize that our differences do not mean deficiency, that we can actually experience someone else as a human being and acknowledge and appreciate the diversity and difference among us, that is a wonderful place to start.
Thank you. I appreciate those core principles that all of us can apply in the context that we live and work. I have a question for Dr. Trujillo. As you mentioned, the Hatch Act. So, you know, the broad question is, I really just don't want to engage in anti-racism work in my workplace. How can we help make it easier for others to enter in when they're really quite resistant?
I think just basically saying what all folks have been saying, educate. Like, don't be afraid to provide the education. And in fact, like specifically about the Hatch Act, because this question has come up multiple times, but especially in the last 5 to 6 months, there are actually presentations and documents that have been put out by the federal government about what you can and can't do, and it is pretty explicit. In fact, a big memo just came out yesterday supporting more of this work, because literally, in a nutshell, the Hatch Act says we just can't, like support a specific party in our federal work. Another fear, though, is that it's not Hatch Act specifically, but it's about political. Well, so we can't. It's too political. Like, that's just, you don't do that, whether you're a psychologist or a medical doctor. We've got to be neutral. Well, the reality is, yes, it is political because it is systemic, and you can't really talk about race and racism without talking about a system. But I know as I started to do this work, we were getting pushback. We even, went all the way up to the VA Equal Opportunity Office to ask, can we do this work? Can we talk? And we were told very clearly, you can do this work, and you really can't actually do this work if you don't talk about how this socio-political system impacts people of color and also people on the upside of power and for majority culture groups. Just like Dr. Farrow said, because our system was created by white folks, it is also created to support and continue racism. And if we don't speak about that and to try to change it from within, it just persists.
Oh, thank you for those comments. And I really appreciate all of the questions that are coming in. I want to direct the next one to Dr. Farrow. And this is very practical. I'll ask you to make it practical. So when clients may have impaired decision-making capacity, especially as we think about caring for older adults, there is the potential, or we could have heightened awareness that assessment of decision-making capacity may be embedded within implicit bias, or perhaps within an organizational system that you outlined. It has really been formed around whiteness.
Yes, absolutely. I think particularly when we're working with older adults and trying to make decisions around, who has capacity, who does not, it can get very tricky. And some of the things that we know that I think are both culturally appropriate as well as best practices when just in working with older adults and geriatrics is really trying to engage family members to have input in the process and make sure that we are really not just kind of looking at the situation with blinders on, but we're taking in the full context. I really think that anytime we are trying to do culturally appropriate work with somebody, whether it's an older adult that's a person of color or somebody who doesn't speak English or whatnot, it is really key that we have a full understanding of the context. And I know that that can be challenging in our current medical system because that does take time to be able to get that information. But those are truly what we know has to happen to be able to do culturally appropriate work.
Thank you. I appreciate this comment and question. Any advice for working with patients who express racist beliefs? So yeah, that's sort of another aspect of how our healthcare teams can often be quite diverse with individuals from different backgrounds. And so then in our seniors clinic, we've experienced when patients have expressed racist thoughts. Anyone interested in addressing this?
One thing I will say on that is, a lot of times I was actually told when I first started, you just can't do it. They won't come back. It's not going to be okay. You should just let it fly around any kind of ism that happens within therapy. But I think the best thing that you can do is get curious. One of my favorite psychologists who specializes in motivational interviewing says, collect the bouquet. Like, don't, so call them in instead of calling them out. And so I will do things like, I'm having a reaction to that statement that you just said. I'd really like to share some feedback. Are you open to it at how others might perceive it? And so even when it's been very overt, I'm amazed at how many veterans and other clients in my private have told me yes. And we've actually had a dialogue. And so I think lean into your discomfort, get curious, and think of compassion.
Thank you for those thoughts. Yeah, go ahead, Dr. Farrow.
I just want to also say that, we did have incidences like this occur in our geriatric primary care clinics. And I think it's also really important, in addition to kind of how do providers interact on that one-on-one level with the patient, who's kind of maybe espousing some racist or other isms, as Dr. Trujillo said. I also think it's very important that the clinic itself, we came together as a clinic and developed policies around how are we going to handle this as a clinic, in terms of we want to make sure that our values are very clear and that we have very clear expectations for how we're interacting with patients. And wanting to be an inclusive environment is something that is very important. And I think it is important, in addition to that individual level, to get with the clinic leaders or the organizational leaders and talk about what are the policies around how we handle this situation, and come up with kind of a standardized way. Because I just think it's really inappropriate that our providers of color are oftentimes the ones targeted, or our MA staff or our nursing staff of color are the ones who are targeted for that. So for white providers like myself, I may not have even known that this was happening. And it takes a kind of collective effort to be able to address it at that policy level.
And I totally concur, because I've worked at the two state hospitals at Fort Logan as well as in Pueblo. And it's important for the culture to make it not okay to behave in racist ways. I don't care if it's by staff or by patients. The culture has to say certain types of behaviors, such as racial slurs and what have you, are not okay. So that type of behavior cannot be condoned. While on one hand, I understand the balance we have to have in terms of being supportive of our clients, of our patients. On the other hand, we also have the obligation to create an environment, a culture which is not hostile for other clients and for staff.
Thank you. We are going to be wrapping up soon. I have one final slide, but before I get to that, I wanted to ask each of you to share what language, or one or two sentences, do you use to introduce this topic with a client or patient? How do we get into this conversation? As we've listened and we maybe see an open door or a need to address it. And Dr. Young, I'll start with you.
Okay, well, one question, and in fact, I might mention that part of the requirement by the Centers for Medicaid and Medicare Services is that you have to include culture in the assessment and treatment of patients. So too oftentimes that's totally ignored. So a very basic question could be, what is your cultural experience? Is culture important to you? what would you identify as your culture as being? And some people will say, I'm white generic, I don't have any culture. And we know that's not true. But that can also be an opening to invite them to talk about culture at a much deeper level, because so oftentimes we speak about it very superficially, and there's many dimensions of culture, and to get people to speak openly and freely, and to give them permission to do that.
Thanks, Dr. Trujillo.
I totally agree. Start with any kind of assessment, even brief, including culture, cultural strengths, curiosity, and expand, providing a little bit of education that when we often think of culture, we mostly think race and ethnicity, that it's broader. But I also think in doing trauma assessment, when I even think about some of like the CAPS-5 or the PCL-5, which are common psychology measures and psychiatric measures, we don't actually ask about race-based stress and trauma. And even the way the DSM is currently written doesn't capture some of this. And so when you are, and besides, typically we do ask about culture, but we also ask about trauma histories when we're doing assessments. I think that it could behoove us to ask, have you experienced any form of trauma, whether overt or covert, everyday, microaggression, maybe use more colloquial terms, because of your identities, plural. This could be your race, your ethnicity, your gender identity. You would be surprised as how many of my veterans of color and clients from other marginalized identities have told me that nobody has ever asked them.
Yeah, thank you. It's amazing. And so, Dr. Farrow, would you be willing to take us through action planning related to this topic? What recommendations would you have for those who are with us or watching the recording as a next step?
Absolutely. Thank you, Dr. Lum. So I think that, again, the purpose of today is to really help stimulate us in thinking about what is it that we can do that maybe is new or different that we haven't done before. And so this is just a list of, what are ways that you can kind of commit to doing actions. So I will do what? Maybe it's one anti-racist action that you can commit to doing within your professional role. What can I or my team do to challenge white supremacy culture within the organization that I'm a part of? Particularly, how can my colleagues and I shine a light on one another or hold one another accountable to develop anti-racism in our daily work? This requires dialogue. This requires folks having the safety and having kind of the communication options to be able to talk with one another about these topics. And then most important, I think, is with whom can I collaborate to collectively address racism as a health issue? It is not part of white culture in general or white cultural values to, as we said, to collaborate. Individualism is something that is really emphasized in lots of our organizations, but we know that collective action is really the key to being effective to this. So just reflecting for yourself, what are some of the things that you can do and who can you do them with so that you have a greater impact? Oh, Hillary, I think you're muted.
Oh. Thank you, Brian, for unmuting me. So thank you all for participating. We will have this recording available and will come out by email. We will also work to save the Q&A, and we'll ask our panelists if they have some sort of next directions or some reflections. So another reason to visit these websites or refer to your email. We do hope that you can continue these conversations, identifying who your fellow journey folks are who desire to engage in this conversation. We appreciate your time today, and thank you to Veteran Community Partnership, the Multidisciplinary Center on Aging here at University of Colorado, and especially thank you to Dr. Trujillo, Dr. Young, and Dr. Farrow. And with that, we will conclude this symposium today. Thanks for joining us.